When two AS genotype carriers meet, how do they steer the odds away from a sickle cell disease? I'm Dr. Babatunde Okewale. I'm a fellow of the Royal College of Obstetricians and Gynecologists, UK. I'm also a member of the British Fertility Society. Discovering that both partners carry the sickle cell trait, AS, can feel like a quiet alarm bell. A 25% chance of a child with full-blown disease, FS. A 50% chance of a carrier, AS. And a 25% chance of an unaffected child, AA. The numbers are stark, but they are not destiny. Modern reproductive science offers a menu of strategies that tilt the odds towards health whilst preserving the hope of a biological child. Sickle cell disease is an autosomal recessive disorder. Each parent contributes one gene, producing the classic Mendelian ratio: 1/4 AA, 1/2 AS, and 1/4 SS. For couples that are determined to avoid the SS outcome, several pathways converge, each with its own blend of promise, practicality, and personal implications. Reproductive options are: number 1, IVF plus PGTM, pre-implantation genetic testing for monogenic disorder. How this works is that eggs are retrieved, fertilized, and grown to the blastocyst stage. The few cells then undergoes biopsy and are screened for the sickle cell mutation. Only AA embryos are then transferred. Why this particular method matters is that it virtually eliminates the risk of an SS child whilst keeping both partners' genetic contributions. The second option is the donor gamete options, and they are threefold. A, egg donor who is an AA plus the partner's sperm. The donor provides the normal AA genotype, whilst the partner's sperm carries the AS genotype, giving a 50% chance of AA and a 50% chance AS carrier offspring. B is sperm donor AA plus partner's egg. This mirrors the above using a normal sperm donor. And C, both donors are AA egg and AA sperm. They produce an entirely AA embryo, and the female partner carries the pregnancy and delivers an AA child, completely removing any carrier risk. Number 3 is in situations where the couples are already pregnant. Prenatal diagnosis is an option that's available at this point in time. A procedure called chorionic villus sampling, CVS, or amniocentesis can determine the fetal genotype early in pregnancy. The consideration to be taken into account in this case is that both CVS and amniocentesis are invasive procedures, and they carry a small miscarriage risk, and they do not change the genetic outcome. They only inform on the subsequent decision making. Number 4 option is adoption, or a type of surrogacy called the traditional surrogacy. They provide a pathway to parenthood that bypasses genetic risks entirely, allowing couples to focus on love and nurture. So how does one weigh choices? Each option carries its own set of considerations: financial cost, physical demands, emotional roller coaster, and ethical reflections. Couples are well advised to consult, if possible, our fertility specialists and genetic counselors at St. Ives Hospital, who can help map out probabilities, logistics, and potential outcomes in a clear and objective manner. In the end, the decision rests on the balance between scientific possibilities and personal values. Whether a couple chooses the precision of IVF plus PGTM the simplicity of donor gametes, the certainty of prenatal testing, or the open-hearted path of adoption. The common thread is the desire to welcome a healthy child into the world. The numbers may be fixed, but the choices are many. And with informed guidance from our fertility specialists, the odds can be shifted decisively in favor of health and hope. For more information on ways to prevent having a sickle cell disease child, you can contact any of our fertility specialists at any of our 5 branches at Ikeja, Ikoyi, Akwonjo, Festac, and Abeokuta on our St. Ives hotline 07034246413. Or you can arrange for a one-on-one virtual video consultation with any of them on the Teledoc app, which can be downloaded on the Apple or Android App Store. Thank you, and God bless.